Hello, happy Teach Me Tuesday. I made it back from Florida just in time for the very best day of the week, which is Tuesday, because we can gather together and talk about some of our favorite NICU things. Today we are in week 4 of our heart month for February, where we have talked about 4 congenital heart diseases. I told you at the beginning that I was saving the best for last, and you might be reading in the title of this slide and thinking, Truncus Arteriosus. That's the best that we've saved for the last. But I love the truncus. I don't know why. Truncus arteriosus is one of my favorite cardiac defects to talk about. In simulation, we have this giant heart that we walk on, that we walk through as if we are a blood cell walking through the heart and tracing the path of the heart. And whenever we get to truncus, I just get so excited because we talk through all the defects and kind of how the blood flow changes. And I don't know. This is just one of my favorites. I guess we all latch on to weird things, but here we go. So let me tell you about truncus today. So truncus arteriosus is this congenital heart defect where you have a singular vessel coming out of your ventricles. One. In a place where there should be 2. So instead of having 2 that kind of, cross under and over each other, I'm trying to make my hands work for you. It's not really working. We'll look at it on the next slide. We're going to have 1 thing coming out. So what I picture in my head, this is probably why I love Truncus arteriosus, is an elephant trunk. So an elephant trunk, when you think about it, is 1 long thing coming down with kind of 2 holes or 2 valves at the bottom where it's, sucks up its water and the elephant does all of its fun things. Probably because I love elephants. Second favorite animal only to giraffes. I love them both so much. But that's what I think about when I think about Truncus arteriosus, is this 1 trunk where it's pulling something up. Now, I actually have no idea what an elephant does inside of there, to be honest. But I do know what the heart does inside of there. And that is that it's taking oxygenated and deoxygenated blood. They're getting mixed together, and there's no differentiation between what is going from the right side over into the lungs and what's going from the left side out into the body. So because of that, we have this constant mixing. We're putting extra pressure on the heart, we're putting extra pressure on the lungs, and we're not going to get great oxygenated blood to the body. So let's think about this for a second. So here is what should be happening with the 2 main vessels that are leaving the heart. You see over here is that the pulmonary artery, we have this lovely little point here, leaves the right side of the heart to take unoxygenated blood to the lungs. It also has waste, carbon dioxide, our old friend, that has to get over to the lungs so that the lungs can exchange the gases at the level of the alveoli. The aorta is taking oxygenated blood away from the left side of the heart out into the body. So here's our aorta. Now, you might remember last week when we talked about the tip I received, which is, if you can picture what color the aorta is, you can picture what the baby is going to look like. So here in a well-functioning normal heart where the 2 vessels are separate, they're crossing. I told you I was behind a slide. You don't have to look at my weird finger diagram. You see your red aorta, right? So the baby's going to be pink and well oxygenated, and you're going to have this great blood traveling everywhere. Well, let's look at truncus. So here with truncus, what color is our aorta? It is this shade of purple. So it is getting mixed blood. You can see that there is some blood coming in, and that is because the Truncus arteriosus relies heavily on a large VSD. So what's interesting, I did not know this in full transparency until a few years ago, is that the name Truncus arteriosus is sometimes called patent Truncus arteriosus because this is how it starts in utero. It starts as 1 kind of trunk, and it's supposed to split in the womb into 2. And when it doesn't, it just is, or I'm sorry, it's not patent, it's persistent. I knew I said that wrong. Persistent Truncus arteriosus is another name for this congenital heart defect, because it has persisted past that week in utero where it is supposed to slit. So 1 part's supposed to become the lower end of the body's main artery, the aorta, and the other is supposed to become the pulmonary artery, and instead it never splits. So the lower wall, you see where I've got this circle drawn, not only do we have that point of the trunk to me, which looks like an elephant trunk, but we also have our large VSD. So we have the mixing of the oxygenated and the deoxygenated blood, which is creating our purple aorta. So our baby is going to be purple. Now, They are not like this dark shade of purple. They do get some oxygen to them. And we also don't see a great picture here of our PDA. This defect doesn't rely as much on the PDA because of the large VSD. So just kind of thinking about that when we talk about medications. So usually this is diagnosed in utero, which can lead to a fetal echo or an MRI. Of course, that is not always the case. Postnatally, if the baby does have signs and symptoms, the baby will get an echo, which is the gold standard, may have an EKG, an MRI, or even a cardiac cath. But those diagnoses, I was thinking about this as I was preparing the slide deck because it's week 4. And we've been talking about 4 different heart defects. And the signs and symptoms are not unique. The signs and symptoms basically are telling us we have a heart defect. And that is what I think is a really key takeaway in talking about this in our last week together, talking about congenital heart disease, is no one's asking you, the bedside nurse, if that's who's watching this, to go and diagnose, oh, hey, I see that the baby has cyanosis, is sleepy, has a heart murmur, is a poor eater. That means that they have Truncus Arteriosus. No. What we are hoping that a bedside nurse would identify is that this change in assessment is going to lead to a bigger dig into what this baby may have. So that's getting the echo, getting the x-ray, getting the EKG. Noticing that, hey, having cyanosis after that first transition period to the lips, the skin, the nails is not normal. Poor eating, poor weight gain, that rapid breathing, profuse sweating, right? This tax the heart is having because of that big space in between and only having the one trunk coming out. So that's what I really want you to take away, not just today from Truncus Arteriosus, but from all 4 weeks, is that ultimately this signs and symptoms are very similar, and the medications are going to be very similar. So that's kind of that repetition of, hey, this is what you should notice. That's a change in your assessment, a change from a normal assessment that could lead you down the road of, am I seeing a congenital heart defect? Which is going to be different than, hey, am I seeing signs of sepsis? Am I seeing signs of respiratory distress? Am I seeing signs of seizure or neurological impairment? When I'm getting this cyanosis, the rapid breathing, the profuse sweating, the poor eating, the lethargy, I should be pointing myself in the direction of, hey, maybe I need to recommend that we get an echo. So what are we going to treat with? I wanted to focus on just these 3 medications. We've talked about PGE a lot, and I'm not going to dig into this too much, especially because PGE is not exactly like our first line of defense. Because of that large VSD, babies with Truncus Arteriosus don't rely as heavily on PGE. They are going to rely on this if there's problems with their aortic arch or anything else going on with the baby, that maybe the VSD isn't large, that we would want some mixing of the blood. The babies may need diuretics. So these diuretics, such as furosemide, are going to help build up that, or prevent the buildup of that fluid and help the baby get those extra fluid off of their body. We see that because of this mixing, there's going to be this tax on the lungs. The lungs are going to be receiving blood that they already did the work on, right? They already exchanged the gases. They're like, whoa, why are you back here? And so it's just putting this extra pressure on the lungs and extra fluid. The heart too is getting, unoxygenated blood back into it. And it's like, wait, I thought I already did this. So there's just all this extra pressure. So diuretics are going to help get some of that extra fluid off. And the inotropic agents such as milrinone or dopamine are really going to help with the contractility and changing the cardiac output. Remember, when we think about cardiac output, the equation of cardiac output is heart rate times stroke volume. So just kind of depending on how we want to best support the baby with the cardiac output so that that one singular vessel, that trunk, can best get the blood out of there. Maybe we need to improve our contractility to get the blood up and out. Maybe we need to make the left ventricle function better. Whatever it is, we're going to use those inotropic agents to help facilitate that. And again, that's relying on your echo to guide that decision. So let's talk about our surgical treatment. Again, I really look at these pictures and I'm like, oh yeah, we're going to go in there, we're going to like put this little valve in here and create a, the second vessel from our one vessel, and then just full patch over our VSD. It's pretty crazy and awesome and amazing. So This surgical procedure is just going to be separating the one singular blood vessel and put it into two, creating a pulmonary artery and an aorta. We're going to close up that VSD so that we can stop the mixing. And now, in this post-surgical picture you see here, the aorta is red. So that means your baby is going to be nice and pink. Your pulmonary artery is blue, right? That's good. We want it to be taking that unoxygenated blood to the lungs. So without surgical correction, these babies obviously would not do well. They can have death in infancy or early childhood. So definitely need to get in and get that surgery done. The long-term outcomes, again, are pretty good for babies with Truncus Arteriosus. There are problems, post-surgical complications, and poor outcomes. The heart valve, sometimes babies outgrow their heart valve. They may need more surgeries in their future. It can lead to pulmonary hypertension or even heart failure. And again, we might have some exercise limitations. These are kids in high school that might have to do different activities in late elementary school because of the effect of that valve and the pressure on the heart. And so you'll be working with your healthcare providers. Lots of follow-up with cardiology throughout your life. And then you can have other medications that you might need to support. They might be on blood pressure medications and then on hypertensive medications for their cholesterol, because we don't want to build up plaque in this heart valve. So lots of follow-up with our cardiology team. Our parent education, making sure we know about those follow-up appointments, managing any potential complications. Again, we want to have a good focus on nutrition. We want to prevent failure to thrive. This might mean high-calorie, low-volume feeds. It might mean a special form of formula, additions to your breast milk. As the baby gets older and is taking solids, what can we do to really promote healthy growth in this baby? And again, especially if we don't have surgery right away, surgery can happen those first 2 months. We want to be being mindful of how much fluid we're giving the baby. So we might need to do higher calories, whether that's in a TPN form, so that and then have less fluid to prevent some of that fluid buildup that can lead to needing diuretics. So again, if we go back and we think, hey, in Truncus Arteriosus, where there's typically two connections, our pulmonary artery coming out of the right side of our heart and our aorta coming out of the left side of the heart. Instead, we just have one outflow valve. So all that mixing of the oxygenated and deoxygenated cells, the red blood cells, are going into the wrong place or getting mixed up. But once we have surgery, most children are going to do well. So thank you for joining me on this heart month. Thank you for coming along for Truncus Arteriosus, which is my favorite congenital heart defect. Sorry I stumbled over a few of my words. Re-entry from vacation is always tricky. March is going to be fun. We're going to do some spring fun things in March, so I hope you will join us. But that's all for today's Teach Me Tuesday, and please comment with any questions you may have, and I will see you next week when it's going to be March. It's wild. See you then.